welcome to today's INNEG lunchtime webinar. Today we are discussing the topic of paediatric traumatic brain injury, and we are very lucky for this session to be presented by Mr Ibrahim Jalloh, and it is in partnership with our charity collaborators, the Child Brain Injury Trust. As a very quick introduction to all the different parties, for those unfamiliar with INNEG, we help serious injury and clinical negligence solicitors accelerate your claim life cycles and reduce unrecoverable costs. Whether you're frustrated, wasting hours trawling Google, phoning secretaries, trying to find the right medical expert, dealing with vague reports or eye-watering fees, if you're irritated by your pagination and records process, or if you're a clinical negligence solicitor and you're tired of chasing your tail looking to screen those claims, then we should talk. With us, with INNEG, you get vetted experts, fast turnaround, management information reporting, and clear, direct communication with one dedicated person. So if any of that resonates with you, then please reach out after the session and we can see whether we are a good fit. Introducing CBIT. So the Child Brain Injury Trust, and as I mentioned, we're doing this session in collaboration with them today. They provide specialist support to more than 2,000 families every year following childhood brain injury. They really are a remarkable charity. They run a wide range of fundraising events, from gin tastings to fun runs and many, many more. So what we'll be doing is we'll be sending out their upcoming calendar of events following the webinar, and I would warmly encourage you to really get involved, because it all helps support the vital work that they do. Now on to the main event. I am delighted to welcome Mr Ibrahim Jalloh. He is a consultant neurosurgeon in Cambridge with a practice covering both paediatric and adult patients. And of course, he is also a medico-legal expert witness. Today, we're going to work along the lines of that Mr Jalloh will speak for approximately 40-45 minutes, followed by a Q&A. And we would ask you to post either throughout the event in the chat at the top or the Q&A if you have any questions for Mr Jalloh, and we will attempt to get through as many as we can following his presentation. So without further ado, Mr Jalloh, thank you very much for joining us today, and I will pass over to you.
Thanks, Leo. It's a real honour. I'm really grateful for the opportunity. So the aim of today, and I'll whittle on for about 40 minutes, but to go through some of the pathophysiology and mechanisms that we understand are important with traumatic brain injury in children. And then just to talk about some of the aspects of management and how that impacts outcomes from these children. So it's really important to remember that children are not young adults. You can't extrapolate what we understand, what we know, how we treat adult traumatic brain injury to children. Firstly, the mechanisms that cause TBI. So I use the term TBI to mean traumatic brain injury. So the mechanisms that cause traumatic brain injury will vary depending on the age. So for instance, in infants, they're prone to diffuse and repetitive injuries of non-accidental injury, which differs very much from the accidents, the bike accidents, the car accidents that older children will suffer. Secondly, there are constitutional factors in children that result in different injuries, a different biological response to injury, such as they tend to have a larger head mass than older children and adults. They have weak neck muscles, particularly younger children, infants, will have relatively pliable skulls, and all of those factors influence how a traumatic brain injury is experienced in a child. And furthermore, there are metabolism, there are neurobiological idiosyncrasies, if you like, of the younger children that impact how a traumatic brain injury behaves in younger children. Traumatic brain injury is a very heterogeneous disease, and therefore it is helpful to, in terms of when we're treating it, when we're trying to predict outcomes, to break it down, to try and categorize it. And this can be done initially on the basis of the mechanism. So we recognize that there are open and closed injuries. In terms of closed injuries, we're quite used to seeing children who are involved in high-speed road traffic collisions, low velocity falls. That tends to be more in elderly people, assault occasionally in children, but relatively rare. And I've already mentioned non-accidental injury, which is the commonest cause of a traumatic brain injury in an infant, really. Occasionally, we get an open head injury, so we get the odd air rifle pellet. I've had a crossbow once recently, but they're relatively rare, and there are different aspects of those head injuries that make them different from closed head injuries. TBI is a heterogeneous disease, as I've said. The other way to think about it are the type of lesions that we see associated with the head injury. So there can be a skull fracture, and that might be of the base of the skull or the vault, so the top bit of the skull. In terms of intracranial injuries that we see, we often see a diffuse axonal acceleration-deceleration injury, for instance, with high-energy car accidents. And there are more focal lesions that we see, and you'll probably be familiar with some of these terms, such as a hematoma, which means a blood clot within the brain substance, versus a contusion, which is a bruise of the brain substance. The brain substance is enclosed in the leathery membrane called the dura. So we have bleeds that are outside the dura, next to the bone. Those are extradural hemorrhages, hematomas. We have bleeds that are beneath the leathery membrane adjacent to the brain. Those are subdural hemorrhages, and sometimes we have bleeding within the brain substance on the surface as well. So there are different lesions that characterize different types of traumatic brain injury, and those have implications for how we treat them and for how they behave and the outcomes. Probably one of the most relevant, important categories is the severity of the head injury. So we use the Glasgow Coma score, which is a scale of conscious level from 3 to 15, 3 indicating deep coma, completely unconscious, 15 is you and I, so normal awake, preserved level of consciousness. And that's determined based on the best score for eye opening, for best verbal response, and for motor commands, ability to follow commands and perform normal movements. So probably the most important classifier for head injury is whether it's a mild head injury, a moderate head injury, or a severe head injury. So the mild head injuries, that includes those people that lose consciousness for a short period, but then regain consciousness, maybe have some concussion, versus the severe head injuries, which are those that require intensive care and often require neurosurgery. So clearly, there's not that much that we can do about the primary injury. We can't avoid the head impacting the ground. We can't prevent the pile-up on the motorway. There's a whole catalogue of silly injuries that children do that I see that we can't avoid. So car surfing, e-scooter stunts, climbing abandoned warehouses, and what I think is my least favourite is horse riding. So those are all activities that we can't avoid. So really, the management of head injury is all about minimizing and preventing a secondary injury. So that's injury that evolves following the episode of impact. And secondary injury involves a whole host of mechanisms that include, this is not an exclusive list, but the important ones are high raised intracranial pressure. So that's increased pressure in the head due to blood clots, due to the brain swelling. Many head injuries are associated with injuries to the body and also with a period of being unconscious. And both of those things can reduce your oxygen levels in the blood or reduce your blood pressure. And both of those factors are really important in terms of propagating the evolving secondary injury. Hypothermia, inflammation, those factors both increase the metabolic demand of the brain. And much of this secondary injury is because of a mismatch, an imbalance between the amount of energy, nutrients, oxygen, blood delivery that the brain needs after a head injury. It just can't be matched. And the ultimate outcome of secondary injury is death of the brain tissue. So the more secondary injury there is, including these factors, the worse the outcome, because essentially you just lose brain tissue. Many of those mechanisms amplify each other. They work in vicious circles, vicious cycles. So, for example, after head injury, you can get some narrowing of blood vessels. That causes swelling of the normal support cells of the neurons. They then release a whole load of neurotransmitters that activate other neurons, which causes more stress to the neurons that are already under stress, metabolic stress, oxidative stress. And then they secrete more factors that further compromise the blood flow. And so there are all these mechanisms that are set up in a vicious circle after a head injury. So the management of traumatic brain injury ideally begins immediately after the injury. So there's a lot of importance on the pre-hospital care. I must say the management of head injury is complex. There are a lot of factors that we have to consider. And therefore, it's really useful. It's really important that we have guidelines to help guide the management. I sat on the NICE Head Injury Guideline Committee, the most recent one, as the paediatric expert in 2023. And this is the body that collects and reviews all the data, all the information on head injuries to determine the best way to manage them. Importantly, at the scene, the paramedics, the first attenders need to avoid hypoxia, need to avoid hypertension for the reasons I've already explained that will exacerbate a head injury. And that's done, and this really is the preserve of severe head injuries. That's done by securing the airway, making sure the patient has lines put in so they can be given fluid, stopping bleeding at the scene. All of those factors will improve outcome after head injury. In the last head injury guideline, we put some advice about tranexamic acid. So that's a medication that is used to stop bleeding. And also, I mean, recently I was asked for an opinion to consider an alleged breach of duty for the defendant, who was an ambulance trust, for a failure to transfer an injured patient direct to the major trauma centre. And that reflects the fact that we now know that if you're treated in a major trauma centre, if you meet no criteria, then the outcomes will be better than if you're taken just to the local hospital. And the supportive care continues in the emergency department, making sure that the airway, that the breathing, that the circulation are all maintained. One of the important decisions that has to be made in A&E, and this is an area of high medical legal activity, is when to perform, and really in whom do you perform a CT scan. So there will be children who have a minor head injury, no loss of consciousness, no symptoms, who clearly it would be inappropriate to perform a CT scan. It's not possible, as I said, it's not appropriate, it's not really safe to perform CT scans willy-nilly in everybody that presents to A&E. So again, NICE has quite clear guidance on what factors should mean that the A&E physicians perform a CT scan. So for instance, a child that presents with drowsiness, a child that has more than 3 episodes of vomiting associated with the loss of consciousness should all undergo a CT head scan within an hour, and that's clear. So I'm going to intermingle some case examples through this talk, but this is one example, a 6-year-old claimant who I was asked to give an opinion on. They presented to A&E following a fall while swinging from a goalpost. The child was initially well, so they didn't meet any criteria for CT scanning, and they were discharged with head injury advice, which was okay in terms of management. The child represented 4 days later with a history of not being able to use their right arm and a suggestion of weakness because of falls, so a suggestion of weakness affecting the legs. One of the things that this case illustrates is sometimes the difficult task that doctors have in assessing the neurology of children who aren't as compliant with examination, obviously, as older children or adults. But certainly this child's reattendance to A&E with a clear history of a focal neurological deficit should have prompted further investigation with a CT head scan, which wasn't done. So that was a clear breach of duty. The same child came back to hospital 5 days later, and they'd had some further low height falls at home, which was in retrospect clearly a symptom of the weakness, and they'd also had a floppy episode. And again, mum told the A&E doctors about ongoing arm weakness. So this time a CT head scan was performed, and the CT head scan was reported as normal, and an MRI was recommended. Actually, unfortunately, in this case, the CT scan wasn't normal. It's obviously not my duty to comment on the breach of duty of radiologists, but there was a subtle abnormality that was picked up at the top of the spine that was visible on the CT scan. And essentially, this was a case of a missed high cervical injury. Sadly, the child presented 7 weeks later with a complete tetraparesis associated with a spinal cord injury. They spent a couple of weeks on the intensive care unit. They needed a halo vest and then formal spinal fixation surgery, and spent several weeks at a spinal injuries unit. I mean, fortunately, the child recovered the ability to walk, but were left with permanent neurological deficits. So there were clear factors that weren't considered appropriately by the initial team that should have prompted further investigation with a scan. And I use this case to illustrate that there's a high proportion of spine injuries, and in particular cervical neck spine injuries associated with head injury. And so it's something that we must never forget. And again, NICE is very helpful in terms of giving clear guidance on when further imaging of the CTs of the spine should be performed in children. And you'll note that that includes dangerous mechanism. The NICE again is quite helpful because they do specify what they mean or give some examples of that. So just coming back to the management of head injury, and really in particular severe traumatic brain injury. So those are those children who present essentially in coma and end up being treated in a medically. And as I've said, the mechanisms that are responsible for secondary injury, which have a huge impact on outcomes, are quite complex, multiple, they all interact. So we need guidelines, we need protocols to manage this complex disease and all these complex factors. And as I've shown you, NICE provides guidance, which helps in terms of management at the scene, the initial resuscitation management. We have guidelines that help in terms of when to perform surgery and the subsequent management. Certainly in children, most centres in the UK will have some guidelines that are loosely based on the Brain Trauma Foundation guidelines, a US group, the most recent of which were published in 2019. And so we use these guidelines to help manage children. Typically, we insert an intracranial pressure monitor into the brain so that we can monitor the pressure inside the head and use that to titrate our various interventions and to prevent dangerous rises in intracranial pressure. We use it to help guide when we perform surgical interventions, such as insertion of drains or decompressive craniectomy, as well as other interventions. So monitoring of intracranial pressure is really the cornerstone of the management of severe traumatic brain injury. Why do we care about intracranial pressure? Essentially, intracranial pressure is the major determinant of cerebral blood flow to the brain. The longer you have a elevated intracranial pressure, the higher it is, the more brain death essentially you get. So the worse your outcome. ICP intracranial pressure is also important because if you get acute rises in intracranial pressure, for instance, due to brain swelling or a blood clot, you can get herniation and deformation of critical brain structures that further exacerbates injury. It can set up a very rapid, vicious cycle that ultimately leads to brainstem death. So another case example that I was asked to give an opinion on. So this was a 6-year-old, a very sad, unfortunate case in that it was a learner driver who mixed up the pedals and struck a 6-year-old who was playing outside. He sustained quite significant injuries with obvious skin lacerations, an open skull fracture, lots of abrasions, degloving injury to the scene. They were in coma at presentation. An extensive severe traumatic brain injury associated with multiple types of traumatic lesions. This child, they spent 14 weeks in hospital. They needed multiple surgeries, an extended period of intensive care treatment to manage the traumatic brain injury, and then 4 months at the Children's Trust, Tadworth. So really this case is to illustrate some of the outcomes of traumatic brain injury, and in particular severe traumatic brain injury. So this child was left with a permanent right-sided weakness affecting their arm and leg, which included spasticity. That includes abnormal stiffness of the muscles. They had dystonia, which means abnormal and sometimes painful contractions of the muscle. They had developed flexion deformities. This is where the joint becomes fixed due to the weakness and stiffness in the muscle. There are secondary problems on growth. So this child had required orthopedic surgery to correct a leg discrepancy, and also surgery to help manage fixed flexion deformity, and they were having orthopedic surveillance of their scoliosis. So there was a wide MDT involved in the care of this child, including rehabilitation medicine, neurologist, physiotherapist, occupational therapist, and so on. So I've already mentioned this child had spasticity, which, as I've said, is stiffness of the muscle, dystonia, abnormal contractions, and also likely something called dysautonomia, which I'll come on to talk about in a second. I also recommended that they have specialist paediatric endocrine screening, and I'll explain why shortly. Clearly quite profound deficits which had significant impacts, significant impairments on all activities of daily living. Their abilities to manage finances would definitely be affected later in life in terms of, and the same was true for employment. They required a high-level multi-professional support team and rehousing in this case to help manage the outcome of this severe TBI. Life expectancy is affected, particularly in severe TBI, and I'll come on to talk about that shortly. So just in terms of thinking of the outcomes of TBI, there are several domains that we have to think about that are often affected after traumatic brain injury, particularly severe TBI. So as this case illustrates, motor symptoms and mobility, and there are secondary complications that can happen because of that. The neurocognitive sequelae, endocrine dysfunction, visual disturbance, hearing loss, etc. These are all factors that we need to consider in terms of the rehabilitation after traumatic brain injury. So specifically the motor symptoms and mobility, a weakness will produce stiffness in the muscle, causing a spasticity. Often there is dystonia due to the abnormal neurological innervation of those muscles, which can be painful. There's something called heterotopic calcification, where you get mineralization of the muscles, again due to the abnormal neurological input to those muscles. As illustrated by the last case, that can cause issues with growth, particularly obviously in children because they're still growing, flexion deformities. All of these factors can cause pain. Fatigue is a big issue in terms of rehabilitation of these children. So to help manage these, as well as physiotherapy, typically once a week, initially occupational therapy, orthoses and splints are needed, sometimes Botox injections every few months, neuro rehabilitation consultant who might undertake a 1 or 2 hour assessment every 6 months. And depending on the other complications, other specialists might be needed to manage the head injury. I mentioned the child that I gave as an example likely suffered with something called dysautonomia. This is where the autonomic nervous system is affected after a traumatic brain injury. So the autonomic nervous system is part of the involuntary nervous system that controls involuntary physiological processes such as heart rate, blood pressure, breathing, body temperature, sweating, pupillary dilatation. And particularly in severe TBI, we do see this particularly in the acute phase after the traumatic brain injury. So whilst the child is on the intensive care unit, they can get disturbances in their autonomic nervous system, and we term this dysautonomia. Sometimes it's called paroxysmal sympathetic hyperactivity. It's difficult to diagnose. There's no clear consensus criteria. Often in the acute setting, it's a diagnosis of exclusion because it can look like sepsis, for instance. But it's increasingly recognised as something, particularly those suffering with a severe TBI, that can cause episodic symptoms down the road, to long-term symptoms that need management. And there are medications that we can give, or rehabilitation specialists or neurologists would give to treat that. Any head injury is associated with an increased risk of seizures over the long term, so an increased risk of developing epilepsy. Clearly, the more severe the head injury, so severe head injury, moderate head injury, mild head injury, the more severe the head injury, the higher the risk of developing epilepsy. You'll notice this curve doesn't plateau until 20 years after the brain injury. So if you're seeing a claimant at 10 years, they'll still have an increase, and they haven't yet developed epilepsy, they'll still have an increased risk of epilepsy for another decade. Increasingly recognised is the endocrine hormone disturbance caused by traumatic brain injury. In children, this would most likely present as issues with growth or precocious or delayed puberty. But it's not straightforward because there's probably an unrecognised incidence of pituitary dysfunction in children in the general population. The analyses that you have to do, measuring hormone levels that naturally fluctuate throughout the day based on other factors, are very complex to interpret. And the symptoms associated with pituitary dysfunction are relatively non-specific. So it's things like fatigue, lethargy, generalized weakness, mood disorder, reduced concentration. They're non-specific, and furthermore, they're all really symptoms and signs that might be associated with a head injury. We looked at this in the NICE guideline committee in 2023, and really there is insufficient evidence to mandate guidance for the clinical management of traumatic brain injury. On the right are guidance that we've published in Cambridge, so the neurotrauma group in Cambridge have published based on our experience of when to formally check pituitary function after a head injury. And the recommendation for those who suffer a severe TBI is at 3 to 6 months after the injury. Certainly my own opinion is that any child that's had a severe head injury should probably be seen by a specialist in paediatric endocrinology to consider whether there's any long-term effects on their pituitary dysfunction. Probably one of the most significant determinants of outcome, and I think arguably one of the most important outcomes after traumatic brain injury, is that on cognition. It's difficult to fully understand this in children because they're developing. So what we really want to understand is how their developmental trajectory has been affected depending on the age of their traumatic brain injury. This is just a highlight from an important study that looked at different aspects of cognition, emotional control, memory, executive function in cohorts. It's an American study in cohorts of traumatic brain injured children suffering with mild, moderate, or severe traumatic brain injury, and compared those to children who had orthopedic injuries but no head injury. And that's important because you need to remove the confounder of having an injury, but also the as I've said, the fact that children are naturally developing. So you need to understand what the effect is on the trajectory. So you do need a comparison group. But what the study shows, which is what we see clinically, is that clearly all domains of neurocognition are affected, regardless of the severity of TBI. I mean, mild TBI has relatively subtle impact as a whole, but certainly moderate and severe TBI will impact traumatic brain injury. And those effects can be experienced for not just 3, 12, 24 months, but for several months after the injury. So in general, the younger you are, the higher your life expectancy after a TBI. The factors that reduce life expectancy after TBI is the most important factors is walking and self-feeding. So non-ambulatory people who need a lot of help with self-care have a worse outcome, and that's because they're prone to secondary complications like chest infections or pressure sores. Other factors that impact life expectancy is epilepsy, because there's a risk of mortality associated with epilepsy, and also continence issues. So just through the risk of urinary tract infections, renal dysfunction, sepsis, all of those things will impact life expectancy. This is the last case just to finish off with. So this is an 8-month-old who was in a car accident. The car was shunted from behind. There were some questions about the car seat, which sometimes comes up, which I won't go into now. Presented with a clinically moderate head injury, was managed initially in a medical coma. They needed a couple of neurosurgical procedures to treat subdural collections. At outcome, so this was about 4 or 5 years after the head injury, they had developed epilepsy. Interestingly, after the head injury, all domains of development were affected. And so that includes motor, fine motor. But those had improved to baseline to what we'd expect for a child of that age, but they had a persistent language delay. So there are a couple of important take-homes from this case. One was about other factors that might contribute to poor or worse developmental outcomes aside from the traumatic brain injury, and it can be difficult to tease these factors out. So for instance, in this case, there was an underlying disorder in the brain called Bessie, and I'll come on to just mention that as a side note shortly. But clearly, at outcome, this child had a very specific language delay, which was out of keeping from the severity of the traumatic brain injury, from how we know these children develop after a traumatic brain injury from the scientific research, and it was also inconsistent with the radiological features of the brain injury. And so the conclusion was that this child likely had an underlying neurodevelopmental disorder in addition to the traumatic brain injury that caused their specific language delay at follow-up. As I mentioned, the other factor in this case was of something called Bessie, which is enlargement of the spaces around the brain. So you can see on this cross-section of the head here, this is the normal brain tissue. There's essentially increased fluid. on the outside of the brain. We see that quite commonly. It's associated with an increase in the head circumference, but when it's idiopathic, when there's no underlying cause, it has a benign cause. It doesn't have any long-term neurodevelopmental complications. But it is associated with some other rare disorders, such as metabolic disorders. But one of the aspects of BESI is that it is a risk factor for developing subdural hemorrhage. It's a vulnerability factor. It makes it easier to develop bleeding on the outside of the brain, as you can imagine. And that was one factor that was relevant in the traumatic brain injury case that I discussed. So just to very briefly finish off with, just to touch on non-accidental injury. So the commonest cause of head injuries that we see in infants, so babies under 12 months, is non-accidental injury, or that's something that we certainly consider. Actually, skull fractures are very common in infants. So I treat or see approximately one infant per week who's suffered a skull fracture. I always feel sorry for the dads. Invariably, it's the dads that have left the baby on the change table who's then rolled off, because obviously they feel terrible about it. But actually, it's very rare for them to be associated with any significant injury or long-term issues. They heal without issue. Obviously, this comes into the arena of the family court, trying to help distinguish in terms of causality, what's likely to be consistent with a household fall mechanism versus non-accidental injury. And there are factors that make one or the other more likely. So scalp swelling is important in terms of trying to understand the timing of such an injury and how that correlates with the testimony from the parents. Sometimes fractures are simple versus complex, and that might give some information in terms of that's useful for the mechanism of injury. And it's important to know that household falls are a very common cause of skull fractures in infants. And from the science, from the literature, we understand the kind of threshold heights above which a child would have to fall before they're likely to sustain a skull fracture. The other kind of classical hallmark of a shaking type injury are subdural collections. They tend to be acute, they tend to be multifocal, so subdural bleeds in multiple compartments of the head, both on the left and right, the midline of the head. Often they're associated with subdural bleeding in the spine. Again, the issues, the neuroradiological issues that become important in these cases are radiological hallmarks of timing. So is there any evidence of past bleeding? We know that birth-related trauma quite readily produces subdural bleeding just normally. So it's important trying to distinguish what might be a birth-related subdural bleed versus one that's been sustained through postnatal trauma. The other features that characterize non-accidental injury, and in particular I'm thinking of shaking type injuries, tend to be hypoxic ischemic injury, which correlates with a clinical presentation of encephalopathy, which means dysfunction of the brain, and as I've mentioned, subdural blood in the spine. So just going to wrap it up. So just to summarize what I've been through today, just to talk about traumatic brain injury in general in children, particularly severe TBIs associated with poor outcomes. We characterize it most importantly based on the clinical presentation, the GCS, the management, the mechanisms that are involved in secondary injury are complex, multiple, they interact. So it's important to use guidelines to help manage, and it's important to use tiered, protocol-driven, target-directed therapy. And that's mostly guided by an intracranial pressure. So one size doesn't fit all for children. We have to specify our interventions based on the information that we get from our tools. So non-compliance with NICE guidelines is a minefield. That's where the difficulties arise in terms of when and who to perform a scan in. Don't forget the the spine. That is again an area that we see sometimes that people forget about. And just in terms of the outcomes of TBI, particularly severe TBI in children, they require a complex, multidisciplinary professional team to manage that. Thank you very much. It's been a real pleasure to give this talk.
Thank you very much, Mr. Jalloh. That was extremely interesting. So really appreciate your time, and I'm sure I can speak on behalf of everyone here to thank you for that. Just before we jump into the Q&As, and there's plenty of questions which have popped up on both the chat and the Q&A function, I would just like to take a moment to jump to a slightly different topic, and just to promote to all of you listening today live, or if you're watching the recording, then this possibly already happened, but we are running the next event with Dr. Mike Taylor, Paediatric Neurologist, about epilepsy focus, particularly on Dravet syndrome, on Wednesday, the 28th of May, again at lunchtime. So we will send you details of that following, and we hope you can join us for that. But back to right now, I was actually looking at considering what you said today, and the first question I wanted to ask is, you mentioned early intervention at the scene of the injury, and I wanted to ask, in your experience, are there particular failings in the pre-hospital or A&E care that emerge in relation to TBI type cases because of perhaps lack of understanding or training, which you see commonly, or would you say that there is the training is very good in relation to the process and the management of TBI at the site of an accident?
So there are issues that arise. I mean, one of the issues with traumatic brain injury is that it's horribly complex, and it's often in the context of other polytrauma, which makes the whole experience for everybody involved quite dirty. There's a lot of factors, so it's often difficult to find specific areas that are maybe diverge quite significantly from the guidelines. As I mentioned in the talk, I have been asked a couple of times about where the child is taken, whether they go to a trauma centre or a major trauma centre. So that is an area where there's clear guidance, and that seems to be something that can be improved on. And then tranexamic acid is a relatively new thing. So again, that is not always given when perhaps it should have been and might have made a difference.
Thank you very much. Well, I'll get straight into it. We have a question here from Eliza Kubik, who has asked, would you include birth brain injury as a result of oxygen starvation as the same type of injury? They can often result in cerebral palsy. Would you recommend CT scans for such type of injury to diagnose CP and or autism?
So, I mean, it's in some ways it's a slightly different entity. So perinatal birth-related events, so hypoglycemia, hypoxia that result in cerebral palsy, will produce a brain injury that is qualitatively different than the traumatic brain injury that I've been talking about today. Certainly, MRI is probably important for the follow-up of those babies to better characterize the degree of brain volume loss. They tend to be managed by paediatricians and neurologists, so I hold my hands up. I'm not an expert on cerebral palsy.
No.
I don't think there's a role for CT, certainly in the acute management of those cases.
Thank you very much. And from Chloe Jackett, if the child is found to have some form of a pituitary dysfunction following brain injury when tested, appreciating that there are no national guidelines of testing as she understands, what interventions / treatment could follow, and what impact, if any, could this have on the fatigue, mood, and other symptoms that you've discussed? So quite a multi-caveated question there.
Yeah, as I mentioned, if the symptoms associated with pituitary dysfunction are relatively non-specific, so if there are, and those include things like fatigue, brain fog, and so if an endocrinologist diagnoses, for instance, a deficiency of cortisol, then they might recommend treatment with hydrocortisone. But also, I mentioned that the interpretation of those tests can be quite complex. So it's certainly something to consider. And I have seen children who have been started on long-term hormone therapy, growth hormone, hydrocortisone after traumatic brain injury. So it at some point it does reach a threshold where it requires treatment, and presumably, logically, at those points, it will be something that is more likely to have an impact symptomatically.
Fantastic, thank you. And moving on, Jenny Tetlow has asked another question focused again slightly on the birth injury angle. But if a newborn sustains a head injury at birth leading to hemorrhage and periatal skull fractures, what do you consider is an appropriate length of time to wait to determine whether any long-term damage has been caused as a result? And she's also asked about the further investigations aside from MRI, but I think you've touched on that. But how long following the injury, I guess whether birth or via a road traffic accident or other, would one potentially have to wait before being able to comment?
That's a good question. As I mentioned, probably one of the most important outcome factors for traumatic brain injury in general are the neurocognitive outcomes. So for those types of injuries of the scale of a skull fracture associated through birth, which in terms of brain injury is a relatively mild brain injury, it's typically just a break in the skull rather than any significant damage to the brain substance itself. And so really you're not worried about hemipresis, you're not worried about all of the awful motor problems that I discussed. It really just, the only question is, has this had an impact on their neurocognition, on their development, on their academic attainment? And as I mentioned, that can be difficult to tease out. There's only one study that specifically looks at this for birth-related skull fractures, and they do find that there are subtle neurocognitive deficits associated with birth-related skull fractures, but they probably aren't that relevant in the real world. So when you test, you find these deficits, but certainly in the children in this study, it didn't affect their academic attainment. In terms of when you should look for it, this is the preserve of neuropsychology, and what I understand is that it's difficult to get meaningful results from the assessments that they do in children under the age of 5. So I think really 5 is when you can start to do detailed neurocognitive assessments that give you a clear breakdown on how they're functioning in different neurocognitive domains.
But again, I'm sure, as you said, you'll defer to the psych specialists on that one, I'm sure. Theo Huckle Casey has asked whether do you take account of post-TBI dementia risks and the work being done in that area by Professor David Sharp and his team in London and obviously elsewhere?
That's a really good question. So I have to be honest, not yet. I think a lot of the outcomes in children in terms of their neurocognitive outcomes are bracketed with some of the data that I showed you, which is, it obviously doesn't extend out 10 to 20 years. But clearly that is something that is important to consider. I think that data, a lot of that data is still relatively premature. But yeah, that's a good point, well raised.
Thank you very much. A couple more here. There's Wilson Law. Aside from Bessie, are there any other ways of medically demonstrating that speech and language delays are idiopathic and not related to any brain injury?
Again, I slightly defer to the neuropsychologist, or at least their reports. If they have a specific deficit in particular domains, it's less likely to be the traumatic brain injury, which would tend to produce a more global picture in terms of deficits. So that's what I can say on that.
Thank you. Jeffrey Simpson-Scott, would you be kind enough to tell us a little more on how much information is usually discussed for each patient during an MDT meeting? For example, is it a detailed discussion or is it a fairly brief discussion?
In terms of clinical MDTs, I assume he's relating to, then like all clinical MDTs, it's usually enough information that's relevant. So for head injured children, it's probably all of the factors that I discussed today in terms of their outcomes.
Thank you. Jamie Swain, what relevance does a family history of brain injuries have when a potential injury has occurred? Would it make any difference as to whether scans are necessary if you knew that there was a family history of brain injury?
No, none. I mean, it's
No.
it's an acquired injury, so it doesn't have any relevance.
Thank you very much. And I think we just have one last question, although you may tell me we've slightly touched on it already. This one is from Connie Pratt. Is there any way to identify the difference between a perinatal stroke and a bleed as a consequence of a traumatic birth?
Certainly, if the neonate has imaging early, then you can tell the difference radiologically. Sometimes you have an infant that has delayed imaging, say at a year or two, which just shows the loss of the brain tissue, and then it's very difficult to know what the mechanism of that brain injury was, whether it was hemorrhage or ischemia. But usually the clinical information surrounding the birth would give you an indicator as to whether it was hypoxia, were there issues in terms of resuscitation, CTG at around the time of birth, or whether it was a hemorrhage. It's very unusual to get a primary parenchymal brain hemorrhage related to birth. So that would be the other factor. There'd usually be an underlying hematological factor, for instance. So just to summarize, usually the clinical information and the radiology would help you distinguish those two things.
Thank you very much. And that brings to the end the questions. Thank you again. That was a good session on questions as well as the presentation. So I think on behalf of everyone, thank you very much, Mr. Jalloh. We will be providing everyone with the slides, with a recording of the event, and with obviously a certificate of attendance for people who require that, as well as all the details of Mr. Jalloh himself, his CV, should anyone want to reach out to him and to request his input on a medico-legal matter. There's many thank yous coming through in the chats. Otherwise, all I can say is thank you very much to CBIT for being our charity partner. Please do check out their upcoming events. There's some great events coming up. And meet us at the next one. The next one is Paediatric Epilepsy by Dr. Michael Taylor later this month. And thank you again, Mr. Jalloh. Really appreciate your time today. Take care, everyone, and have a lovely day.